Very good morning. The lively discussion on moving on to this session on antenatal intervention for fetal obstructive uropathy. And I have taken current perspectives and see what is current. So when you look at obstructive uropathy in the pregnancy period, we have these four concerns. You have a baby which is having an upper tract obstruction, a pelvic obstruction, or a baby which is having a uretrovesical junction obstruction or a VUR, which we can't pick up very well. Or you have a baby which is having a posterior urethral valve or obstruction of the bladder outlet, or you have a fetus which is having a congenital uretrovesical. So when you look at the perspective of fetal intervention, there is good amount of data and evidence that poking the uterus for an upper tract obstruction or a suspected reflexing or a uretrovesical obstruction is only going to cause more harm. So we completely avoid that. So that leaves us with two areas of discussion, that is your posterior urethral valve obstruction and congenital uretrovesical. And let's look at what is the evidence for that and what data that we have when we look at this. There are some numbers I put up here. These numbers are extremely familiar to you. But then, what I want to reiterate is that when I start with looking at posterior urethral obstruction for a case of an intervention in the prenatal period, there is a triad of findings that we see. We have a dilated bladder with the keyhole sign, bilateral hydroureteral nephrosis, and a reduced lighter. But this classical triad, which is set to pick up your PUV, is seen in only 1/3 of the cases of PUV. So you actually are finding it very, very difficult to pick up the problem with definitiveness in the prenatal period in over 2/3 of the cases. The natural history for a baby with a lower tract obstruction is extremely variable. You have a baby which is having a hydroureteral nephrosis. Sometimes the pressure in the system can get too much. You can have a rupture of the calyces causing a perinephral urinoma. You can have a rupture of the bladder causing a urinary ascites. You can have a rupture of the bladder causing a urinary ascites, or you can have a progressive obstruction causing an echogenic cystic kidney disease, which is causing impairment of the function of the kidney. When we looked at the histology of the kidneys at our own unit, between babies having a lower and an upper tract obstruction, it gives us some perspective. Those with the lower tract obstruction tended to have much lower number of glomeruli and tended to have much higher degree of interstitial fibrosis, cortical cysts, and prenatal identification of oligohydramnios compared to the upper tract obstruction, which makes this a possible candidate for intervention to prevent progressive decontamination. And what happens is that when you have an obstructive pathology in the lower tract in the pregnancy period, you have a bladder neck dilatation, you have bladder wall thickening, you have all this irregularity in the bladder. These are all signs that we try to pick up. We also try to pick up if there is a dilated ureter and a renal parenchymal abnormality in these cases. And when I see these cases, I don't stop with that because there is an additional issue of the bladder. So I can simply go and relieve the obstruction, but what happens to the bladder at the end of the day? Very, very less is spoken about the bladder, more is spoken about the kidney, but it is known very well that progressive obstruction through the prenatal period due to high amount of urethral resistance causes a hypertrophic contractile bladder, which may end up having dysfunction despite you treating the renal pathology. So with this background, we go into section 1 of this discussion, which is what is the evidence before. And I take you back close to 27 years ago, where this paper on the prenatal intervention for hydronephrosis was put up. And let's run through it as to what was given in that. It says hydronephrosis is an experimental technique, that is prenatal intervention. There is no solid evidence to suggest that relief of obstruction improves the renal function, but some evidence that if you correct the oligohydramnios, it can improve the pulmonary function. We shall move on in that paper. We need to avoid intervention when it is not required. Examination begins with an in-depth ultrasound to confirm the diagnosis, level of obstruction, associated malformation. A persistent distended bladder with a dilated upper tract means there could be an intervention. You should always think of chromosomal problems. Intervention rarely indicated in a female fetus. And when you move on, it says High-grade bladder outlet obstruction with a very low amniotic fluid should undergo a tap for urine evaluation, and the presence of a normal amniotic fluid is a relative contraindication to intervention. And if severe biochemical results are predictive of renal dysplasia, then intervention should not be considered, and in utero decompression may not preserve renal or pulmonary function also. So this is what is the evidence which came up to us 27 years ago. So we shall move on to the series of cases and the evidence that is there currently, and then try to sum up to see what we have things different from what was there close to 3 decades ago. Let's start with 3 cases. This is a case where you have a distended bladder, a dilated posterior urethra, a classical keyhole sign, a bilateral hydronephrosis, and you have a normal liger. Would we go and intervene in this case? Let's go to case 2. This patient had a left kidney which was normal, right kidney severely hydronephrotic. We had a classical sign of a keyhole sign, which was suggestive of a posterior urethral obstruction, but only one kidney is hydronephrotic now. The liger was normal in this case. This patient came to us for an intervention saying, they told me that this baby has got a lower tract obstruction, and I want this baby somehow. Can you do something which can potentially protect the left kidney? Because they said the left kidney is strong. So do I go and intervene in this case? Let's look at the third case. This was a scan at 20 weeks. Normal bladder, normal kidney, normal liger, everything benign. At 28 weeks, you have a baby which is having a normal liger and kidneys are okay, but there is significant amount of ascites, and this patient, when I saw them back 3 weeks later, then there is an upper tract obstruction, there is a bilateral hydronephrosis, and then you have a distended bladder. There is a suggestion of a possible rent in the bladder. Whether my eyes are playing games, I do not know. And this is a baby having a urinary ascites. So there was a lower tract obstruction, but the clinical presentation was not a hydroureteronephrosis. It was a urinary ascites first, and the hydronephrosis next, the bladder distension next. So do I go and intervene in this particular case? So I have 3 different cases completely. Each one, do I have to intervene or not, is something that we have to think of. So how do we look at that? We'll again look at how we need to process this. The first step in this regard is considering a proper evaluation. And proper evaluation means we have to make a proper diagnosis. And as I said, around 35% of the patients only have a classical triad which is suggestive of a posterior urethral valve. Because that's one of the conditions where I think of intervention. If I go back to my first slide. So if I see this, a keyhole sign has got only a 48% sensitivity, and a hydronephrosis has got a much, bilateral hydronephrosis has got an 88% sensitivity, and a significant megacystis has got around a 50% sensitivity. So if I look at the prenatal diagnostic features, megacystis, thickened bladder wall, keyhole sign, hydroureteronephrosis, when you have multiple signs, then you think that possibly you are looking at an obstructive pathology, possibly a posterior urethral valve, and that's what we tell the patients also. And it can still be any of this, and we have to see what we can look at. So what if we see the problem in the early part of the pregnancy? In the early part of the pregnancy, when I see a bladder size which is around 7 to 15 mm in the longitudinal diameter, it's more in favor of some intrinsic chromosomal pathology which I investigate. And I'm still not worried about it if the chromosomal problems are not there. Majority regress, I don't even think of intervention. It's those where the bladder size is more than 15 mm in the first trimester, they never regress. And especially those where the bladder size is over 20-25 mm, they are most definitively an obstructive pathology. As you see in this case, this was a multi-system anomaly, and this baby had a severe hydronephrosis, and this baby had a distended bladder. An autopsy study showed that this baby had a urethral attenuation. So very, very early obstruction presentation in the pregnancy with a very severe bladder distension, more in favor of a urethral attenuation rather than a posterior urethral valve. A second trimester diagnosis, again we look at the longitudinal bladder length, but bladder is a dynamic structure, fills, empties. What I measure as 25 mm can be measured as 30 mm by the next operator. But one rule of thumb, you have this keyhole sign, and second, there is no emptying of the bladder seen for over 40 minutes, can be possibly considered as one of the features of considering a second trimester obstructive pathology. So what is the current recommendation for prenatal suspicion? This is the consensus of this ERK-NET, acute obstructive uropathy group. They said prenatal suspicion must have a presence of a megacystis, bladder diameter, they've said over 15 millimeter in the first trimester, second and third trimester, no number, it's only clinical and subjective assessment. The second aspect we look at prenatal evaluation is what are the outcomes. So this was the biggest paper that is there on prenatal megacystis, which are related to lower urinary tract obstruction. We have some part to play because a large number of cases in this subgroup were part of our series. We had around 418 cases in this group, and what was seen was only 229 ultimately reached the postnatal period to meet all of your teeth here. And what was there in that? Around 30% underwent termination, 20% underwent demise, and 55% were alive. And among those who were alive, 70% had a lower urinary tract obstruction. So a large bladder, only 70% of those who survived after birth had a lower urinary tract obstruction. And of that, only 50% had a PUD. Remaining had a urethral stenosis or atresia. All of the scenarios where I don't consider a prenatal intervention at all. And again, when I look at the postnatal diagnosis of a prenatal lower urinary obstruction, it can be part of anorectal malformations which can be commonly associated, which is something that we do tell the family that it may not be a lower urinary obstruction where someone sees you and then relieves the obstruction. The way we might also have other pathologies which can be part of it. So a very detailed structural assessment is very, very important for me before I consider a prenatal intervention. So the key message there, detailed anatomical survey, rule out genetic syndromes, chromosomal error, classify them into Luto. 27 years later, that key message has not changed at all what I saw in that first paper, and I still put up the reference of 1997. With that, we go to the fourth part of our discussion on intervention as to how do we identify the candidates for intervention, or rather, how do we eliminate those whom we should not do anything. Because when you look at prenatal intervention, first and foremost thing is when you should not do. When you know when you do not do, then you have reached bliss. So if you look at the questions, I put those questions to myself. Will I restore the amniotic fluid after doing an intervention? Is it going to reverse the obstruction? Is it going to create a reasonable urinary biochemistry? Is it going to avoid renal replacement therapy or possibly delay the renal replacement therapy till the child grows up into adulthood? So the candidates are one, a child having a posterior urethral valve, good renal function or mildly compromised, and our goals when I talk to the family are we are going to try to see if we can stop progressive renal damage, improve the liker so that we can prolong the pregnancy and avoid prematurity, because prematurity is a very, very significant cause of loss of the nephron number in the adult. So I look at the kidney evaluation, I can see a bright white kidney like this, or I can see a kidney when I zoom it up, I can see these tiny cysts here, or I can see a kidney where the calyces are significantly dilated enough and I can't see any parenchyma at all, or I see a bilateral severe hydronephrosis with a bright white kidney, or there is a perinephric urinoma right there, or there is not only that but also a very poor corticomedullary differentiation. I have this picture in front of me. If I see any of these images on the ultrasound, I tell the family that going and poking the uterus is not going to help. There is a significant renal damage which has already happened and we may not be able to reverse the pathology. Very similarly, I go and look at the bladder because the kidney system involves a bladder. I can look at a keyhole sign. I can see a grossly distended bladder. I can see a possible rent or a urinary ascites. Or sometimes I see a very geographic bladder. When I see something like this, I'm extremely worried because I'm not sure whether it's a bladder at all. It may be a common cloacal pouch which they are presuming to be a distended bladder. Or it can be a very thick-walled bladder which we are very worried about, because despite treatment you might end up having a bladder dysfunction after birth, or the worst case scenario where you have a bladder that is not distending at all, it is very small and thick-walled. And for this perspective, I put up these three pictures. Case 1, we have a classical keyhole sign. Autopsy showed a urethral atresia. Case 2, again a classical keyhole sign. Autopsy in our unit showed that was a posterior urethral valve. Case 3, there was no keyhole at all. It's a distended bladder. Autopsy showed a PUV. So what do I take as a PUV with definitiveness? Can I do that? The answer is very, very challenging. I only presume that it could be a PUV if I see these common findings. So the keyholes are not equal to valves. The third aspect, once we reach the kidney and the bladder, we reach a liquor, we look for normal liquor or a reduced liquor or an anhydramnios. It is the center group where there is a slight reduction in the liquor where we consider intervention, not in group 1 or group 3. So that's the recommendation there. Presence of oligohydramnios is the most important thing that is associated with survival after birth. So try to see if we can improve that. Parenchymal echogenicity to some extent has got some relevance, but as individual parameters, they are not very reliable predictors of long-term renal function. But when you combine them all together, it does have messages. So the key message prior to intervention is do an extended prenatal renal sonography, extended bladder assessment, liquor assessment, structural malformation, bad kidney, bad liquor, bad bladder, no intervention at all. 18 minutes of my talk have gone. I've still not gone into the intervention because that clearly tells you how much we think before we actually poke the uterus. Then we still go and look at it with a little more perspective. We see if the bladder cycling can help. And again, varying evidence, the current recent Delphi consensus says that the bladder refill, I do a vasicocentesis, empty the bladder fully. If there is obstruction, if there is a partial obstruction, it should refill, and it also tells that the bladder is still functioning. So that is one thought that we use for thinking of an obstruction. And we have a discussion on renal function testing, so I will go back into it again. We do 2 taps of the bladder like this, and we check the urine biochemistry, and we do the beta 2 microglobulin, and use these cutoff numbers to consider good or bad biochemistry. But again, current recommendation, none of these biomarkers are able to reliably predict postnatal kidney function at all. And the current consensus, as recent as May 24, bladder refill urine biochemistry can be utilized as part of workup for prognostic counseling, but no clarity because the experts in the group had 50-50 whether you can go or do not go. So do we use this as part of our counseling and evaluation? Yes, we do, because only then we have some direction as to what direction we can go to. And the fifth part of this discussion is whom do we intervene? For that we classify them. We use this Ruano classification prenatally to consider what I need to intervene. There are 4 groups. I can't go into these groups. I will look at only group 2 where you have a hyperechogenic kidney, favorable electrolytes, oligohydramnios, then we consider intervention. And here intervention is to prevent secondary pulmonary hyperplasia and also try to prevent renal damage. Third group also I consider intervention because I consider intervention for them to avoid complications of anhydramnios and prevent further renal impairment. But here I do counsel the family in significance that the prognosis may not be great. So the key message C, we use the Ruano classification. Stage 2, stage 3 are the candidates for intervention, and this table we are able to obtain only when we do that extended assessment. Only then we are able to put them into each of these groups. And once we have reached that point, then we think how and where to intervene. When we have different methods of intervention, and the open vesicostomies are no longer in mode, we have only the percutaneous method and the fetoscopic method. The percutaneous method, we have the vesicoamniotic shunt. The fetoscopic method, we have the cystoscopic fulguration of the valve. The main role here is to restore the amniotic fluid volume, to decompress the kidney urinary bladder system, promote cyclical detrusor contraction, bladder contraction, and to avoid lung compromise. So when we talk to the patient during counseling, we tell them these are the 4 goals, these are the aim with which we go and do the intervention. We don't go with the aim that is going to be a one-time treatment with complete solution in the prenatal period. So vesicoamniotic shunting basically tries to cycle the bladder. We are trying to give up an alternative pathway, and wherein we are trying to decompress the kidney and reduce the pressure of the renal system to see if the kidney damage can be avoided. And this is the technique where we have an obstruction there. and we puncture through the maternal abdominal wall, and we puncture the urinary bladder, and once the trocar is placed into the bladder, the shunt is deployed inside and part of the shunt drains outside. So we have these shunts that are available. What we use is the Harrison shunt. Double basket shunt is less available. It's available from Japan. It's extraordinarily expensive. One shunt even costs up to 1.25 to 1.3 lakhs. So what we use is a Harrison shunt here for utilization. These are the tools we have. We have the trocar, we have the guide wire, and we have the introducer set, and we have the local anesthetic. Very small number of tools that we do actually require. So this is how we actually puncture inside. We set up the system outside the tray. This is the trocar which actually goes inside the bladder, and we check if the trocar is functioning well. And we take the shunt. The shunt has got two ends. One end which actually goes inside the bladder, and one end that goes outside the bladder into the amniotic cavity. And we thread the guide wire and extend the shunt that way. And once we load the shunt, we check the trocar system, and for that we have the introducer set. The introducer set is pushed across the guide wire with the shunt, and what we do is we try to put this inside that trocar and push it inside. And how do we do that? We choose a position where the shunt tube can come down posteriorly, because we don't want the shunt tube to be jutting out from the anterior abdominal wall, because then the baby can easily pull it out. We want the baby preferably to be in a prone position to put the shunt. So we go from the back side of the baby and we make a stab incision and we put the trocar inside, and the trocar goes inside the bladder. And the moment it goes inside the bladder, what we do is we hold the top with a small tube, because we don't want the bladder to empty out fully, because it's a large needle. If the bladder empties out fully, you can no longer put the shunt, and then we put the shunt tube inside. The shunt tube is pushed inside. It's got markings where we go up to the first marking, and then the guide wire is removed, and then we push the red introducer slowly through it. And the last point we keep seeing on the screen where the tube is inside the bladder, and this trocar is tilted slightly so that the shunt tube comes out posteriorly. So once we have done that and you have pulled out the trocar completely, you can actually see the cycling here. Color is actually showing the fluid that is going through the shunt tube into the amniotic cavity. So it's a simple procedure, takes hardly 5 minutes to perform once you start the procedure. This is the shunt inside the bladder, and this is a hydronephrosis in this particular case. But there can be complications. You can have spontaneous rupture of membranes, you can have a shunt dislodgement. You may need to do a repeat shunting, the shunt may get blocked, it may no longer do its work, you can have a risk of infection, you can have a risk of bladder rupture also, and all this need to be considered whenever you evaluate this in the whenever you counsel the patient for these procedures. And this is a baby actually where the shunt slipped into the peritoneal cavity of the baby. Postnatally, the treatment was done. The shunt tube was actually pulled out after birth. So what is the evidence that says? I'm not going to this old trial, I'm just going into the newer papers that are there. 2017 paper, updated meta-analysis, vesicular amniotic shunt improves survival. So that's all it says. It says that overall survival increases by around 60%, but it gives no information on protection of bladder function or protection of renal function. Again, 2020 paper, little bit subgroup analysis they have done. They said the shunting was associated with a higher perinatal survival in those where the bladder biochemistry is slightly becoming worse, rather than those where the bladder biochemistry is completely normal. That's why this lack of consensus on what you need to intervene or not is there. So the final Delphi consensus is there, 90% agreement that this must be the first line treatment for Bluetooth. When you see stage 2 or stage 3, minimum gestation is above 16 to 17 weeks of gestation. We don't do it after 27, 28 weeks of gestation. Can we do it in the first trimester? There are some recent papers in 2022 which have said in these babies, they have a moribund bad prognosis. Should we do something to improve the outcome? Only 10 cases And what they've seen in those 10 cases, 3 had PUV, 2 urethral stenosis, 1 had a anorectal adhesion, 1 had a disorder of sexual development. Can you just see the extent of associated problems that are there when there is an early presentation? Again, 2022 paper where they tried to put in a shunt in 47 babies very early in gestation prior to 16 weeks. They quoted a 58% survival rate and good renal function, but very poor data at the because renal function was only determined at the time the baby was born. We never know what these babies have at the age of 2 years or 3 years. So the current consensus what we do not offer any prenatal treatment or intervention for a first trimester diagnosis of lower urinary tract obstruction. So we then go to the second aspect, that is a cystoscopy, that is the fulguration of the posterior valve. In cystoscopy helps you one important thing. Till now we are not even sure whether it's a PUV or a stenosis or not. When you actually put the scope, you are able to diagnose the exact etiology in over 90%. So you're actually going and seeing and treating, so is it really better? And in these cases we have very strict criteria. The criteria are very similar to what I described above. You have to have good appearance of kidney and stage 2, stage 3 of the Ruama classification. And what was seen again in these cases is we use a scope. We have an 8 fringe curved sheet that is there, and we have a Y connector to pushing the scope or to pushing the laser fiber on the side, and it's done under local anesthesia on the skin. We also give fetal anesthesia by pancreas intramuscularly. So this is what actually happens. We put the scope inside, it's a curved scope, and it's going inside the bladder. It's 2.2 mm trocar, 1 mm fetoscope, very tiny fetoscope. We actually go and see up to the bladder neck. If there is a membrane-like obstruction, then we can do fulguration. But what is essential is that once we go in and see, and we see that it's not a posterior valve, we don't do anything, we come out and explain to the family. So essentially it's a diagnostic cystoscopy which can proceed to an operative cystoscopy when you look at it from a prenatal perspective. So this is actually a patient for whom a fenestration of a PUV was done. So we put the cystoscope inside the bladder and we go inside, we find the location where we need to do that puncture, and using a 400 nanometer laser fiber, multiple punctures are made. And at the end of this baby actually had a proper filling entry of the bladder when we followed it up. The LICA was normal, postnatal treatment also was done. This baby required treatment after birth also, and was actually doing well at the time of current evaluation. But this is not the case every single time. We've also had scenarios where we have done the validation and the kidneys have still become cystic dysplastic when we have followed up in the pregnancy period. So again, complications, very important to counsel them. There can be a possible of a vesicocutaneous fistula, recurrence of the obstruction, despite whatever treatment we do, progressive obstructive pathology can happen. So this is still under course what we say under an experimental treatment. We tell the family, we take a proper consent, and we tell them we do a diagnostic cystoscopy and decide whether we need to have a therapy. The last part of this talk is on the other two aspects of lower urinary obstruction. That's a uropathy. Very rarely picked up prenatal period because most of them the symptoms don't present. How do we usually see? We see as a bladder within a bladder sign. We see the cystic structure inside the bladder, and it doesn't collapse, and you have a bilateral hydrourethral necrosis. And that is one of the indications where we need to consider that relieving the obstruction, will it help, because it's causing a bilateral upper tract obstruction. So this is one particular case we have actually got a puncture. What we do is we do 18 gauge needle goes inside and we can puncture it, or we can actually do a cystoscopic ablation. So we've actually put in a scope inside and we have ablated the urethrocy, punctured the urethrocy, so that we are trying to relieve the obstruction. And you can see that after the puncture, that cyst has collapsed, it's become white and echogenic, it's no longer distended, and this pregnancy actually had a good outcome. Evidence on this scars, because it's a rare condition, very few case series. This is a large case series that was there, and large meaning it had only 10 cases, and all different things I did. Some of them are fetoscopic puncture like what we did, some of them are ultrasound guided puncture with a 20 gauge needle, some have actually put in a balloon and inflated to rupture the urethrocy, Again, very, very scant evidence because we do not know what kind of vesiculated reflex it is going to cause at the end of treatment in the prenatal period. So again, when you look at prenatal treatment, surgery in the second trimester is still considered experimental, should only be performed in treatment centers following counseling and informed consent, and we use candidates for intervention when there is a bilateral hydronephrosis, not when there is a unilateral hydronephrosis that we need to see, because we still have one function. Just going to complete this talk. And that brings us to the last aspect of the talk, which is fetal therapy for a urinary ascites. I said right at the beginning that sometimes you have a bladder ruptures and you have a massive urinary ascites that is where the abdomen is significantly distended. And what is the worry in these cases? In these cases, we may think the bladder is ruptured, pressure in the system is there, so the bladder rupture is actually protected to the upper tract. We really do not have evidence of that. But what is more worrying, if the abdomen distends so much for a prolonged period in the pregnancy, it's going to have pulmonary hypoplasia because of diaphragmatic compression. So in these cases, one consideration we do give is what we need to see to improve or prevent pulmonary hypoplasia to avoid prolonged diaphragmatic compression. Especially if it happens in the mid-trimester, one of the things we consider is to do an aspiration, especially when there is a ascitic fluid which is very, very large. It hardly presents in the mid-trimester. We usually see the presentation only after 30 weeks. This baby, we did an aspiration twice and the baby was survived and currently on fluid. A very similar case where we saw all this distended bladder with the thin cortex that was there. We did a sampling for seeing the renal function. Second sampling, she came back 48 hours later, the bladder ruptured. An iatrogenic complication. Sometimes when you actually do a vesicocentesis, you can have a urinary ascites. This unfortunately, within a few weeks in progress, the ascites became significant, and what we also ended up is having a renal dysfunction at around 30 weeks. You can see this cortical cyst there. So what I want to say is that the progression in the prenatal period sometimes cannot be very, very predictable. So intervention in urinary ascites, no evidence, aspiration only if severe to avoid lung compression. You may need for a repeat aspiration or tap in severe ascites prior to delivery. So in summary, I just want to take a word to go back to our evidence 27 years ago. There simply has not been very significant change from what data we had over 3 decades ago. What has come up in newer states is that newer shunts with better presence that they don't get dislodged, and the prenatal cystoscopic ablation for which we still need greater amount of data. Thank you so much.